Okay, thank you for the introduction. So yes, I'm Lindsey Collins. I work, as you can see from my slides, for Tees and Wear Valleys, which is a mental health and learning disability trust in the northeast of England. It's quite a large trust, just to give you some idea of the kind of group that I work into. We cover an area of about 3,600 square miles with a population of about 1.6 million people. So it's quite a big trust that we work for, and I work into 10 different memory clinics within our trust. So just to give you a bit of background about the team that I work in, we're called the Nutrition and Dysphagia team. We're a fairly unique team in that we have both speech and language therapists and dietitians working within our team. And we work within the mental health services for older people directorate within our trust, which also includes 2 young onset dementia teams as well. We set up the team about 3 years ago, just coming up now, and our referral rates have increased quite significantly in that time. Within the first couple of years, they increased by 98% did our referrals. So we're really demonstrating a good need for speech and language therapy and dietetic services for old people. Okay. So first of all, I thought I'd just give a bit of an overview as to why speech and language therapists are needed. And I hope I'm kind of preaching to the converted a little bit here, and that the need for speech and language therapy input is recognised. I've tried to pitch it quite general, because there'll be some of you who perhaps do have specialist speech and language therapists working within your services. For others, you might rely on generalist speech and language therapists. And for others, you might not have access to speech therapists within your services. I'm seeing a few nods around. So I accept that we're quite privileged within our trust to have speech and language therapy input. So first of all, most, and some people might say all people with dementia will have communication deficits, and that will be at some stage within their dementia. And for some, it might be the primary problem, the primary presentation might be problems with communication. The Alzheimer's Society did a study a couple of years ago where they looked at the key quality of life indicators for people with dementia, and the #1 priority for people with dementia was relationships and having someone to talk to, and number 6 on that list for quality of life was being able to communicate. So it's a really significant part of people's lives, and I'm sure for everyone here, if you had difficulties in communicating, it has a massive impact on every aspect of your lives. And as well, with people with memory problems, we rely so much on the context of what's happened before, what's been said previously, to enable us to understand and engage in a conversation. So the memory problems also do have an impact on someone's ability to communicate. Okay. So also then, speech and language therapists work with people with eating, drinking and swallowing problems. We usually term it dysphagia, but I think that can be a bit narrowing really for what we do with working with people with dementia. The physical dysphagia, so physical swallowing problems, is a part of what we help with, but it's also looking at generally those eating and drinking problems. So looking at the whole package of someone having a meal and having snacks, and that's where we work really closely with the dietitians within our service to ensure that someone's having kind of least risk foods that are also nutritious for them. A patient I saw just at the beginning of the week had said to me that the idea of eating fills him with dread because of his swallowing problems, particularly in public. It's really impacted on his ability to go out with his wife and have a meal, particularly when they're meeting up with friends. So having those difficulties does have a really significant impact. And with a lot of the symptoms, the problems that come with having dementia, with communication difficulties and eating and drinking problems, we can't necessarily fix those problems. I'm not a speech therapist with a magic wand, unfortunately, but what we do try to do is reduce the impact that those problems have on people's lives, for the people who have a diagnosis of dementia, but also for their carers, family members, professional staff and paid carers as well. So what exactly is it that speech and language therapists do in dementia care? And that's a question a lot of speech therapists who don't work in dementia care will ask me, because they don't really know what it is that I do. And I have to say it varies. Throughout the UK, it definitely varies, and throughout the world, it will vary in what speech and language therapists do. In the UK, it's a relatively new role for speech and language therapists to specialise very much so in the role of working with people with dementia. And because of this, there's quite significant variation throughout the country. We do have a position paper which was written by our governing body, the Royal College of Speech and Language Therapists, and that position paper was written in 2006, and we're currently in the process of updating that to meet with kind of new evidence and new ways of working, because in those few years there have been quite a lot of changes as the role has developed and different needs have been identified. So I thought I'd start by going through kind of the different areas of work that we're involved in, and then I've got some case studies at the end so that I can demonstrate hopefully a bit more clearly and more practically what it is that speech and language therapists can do. But I can't guarantee that every speech and language therapist will do all of these things, and obviously other speech therapists might do different things to this. So first of all, we do have quite a significant role to play in diagnosis and being involved in pre-diagnostic assessments. We do a lot of the language assessments that are quite detailed in being able to pick out the subtleties of some of the language-based dementias. So the primary progressive aphasias, semantic dementias, the different dementias with a language presentation. And often the assessments that are done within the memory clinic aren't detailed enough to be able to pick out those differences. Certainly the memory clinics that I work into are what they say on the tin. They're memory clinics. The focus is on the memory problems, and often there's a lot of challenges that then come up with some of the diagnoses of people with more language-based, language-predominant dementias. So we do get involved in doing those assessments, and then working alongside with the neuropsych assessments, the other cognitive testing, as well as imaging to contribute towards that diagnosis. Okay. We also, one of the things that I certainly get involved in is assisting other members of the multidisciplinary team to help them with their assessments, because often the assessments that are used are very verbal based. They require verbal skills in order to complete those assessments, as well as kind of language processing skills. So we can help with adapting some of the assessments. I've worked with a colleague to adapt the MMSE for people who have communication difficulties. Now, obviously, it's not standardised, it's not validated in the same way, but it just gives those opportunities to be able to discuss, to assess those cognitive domains that are assessed within some of the memory and cognitive testing. Okay, so it's not just the diagnostic assessments that we get involved in, it's also more general communication assessments. So for people who might have received a diagnosis but are having difficulty still in communicating. And we'll look at all different parts of language processing, so expressive and receptive language. And from that, the main aim of those assessments really is to develop a profile of skills and difficulties for that person, and in order to give strategies, individualised strategies that will then use those skills to address the difficulties and to enable them to communicate as effectively as they can. We also, from the assessment, give advice then to carers as well. in order to give them some strategies. As well, with the communication assessments, we have different assessments that will look at non-verbal communication, as well as giving people the opportunity to respond non-verbally to assessment. So if someone's expected to give a verbal response and that's difficult for them, then we do a lot of the kind of non-verbal memory testing. So rather than having to remember a series of words, can they remember a series of visual images, and can they replicate them? So you can still use that visually to do the immediate and then delayed recall assessments, and that's something that features within our communication assessments. The other thing that the other assessments that we can do is to look at kind of pre and post treatment, to look at the progression. So if someone's then put on a medication or participates in an intervention, then sometimes we get involved with looking at assessment to see whether that intervention has had any benefit for that person. And one other important area that we get involved in is to do with the capacity assessments to assess for mental capacity. Obviously, anyone can do those capacity assessments, but for people with communication difficulties, they often need that additional support to enable them to understand the information presented to them, and then in order to give a response to that. I'm working with a lady at the moment who has young onset dementia and was diagnosed fairly recently, but there are some safeguarding issues surrounding her ability to care for her children. So it's really important for us to understand at what level her understanding is in order to assess her capacity to take care of her children. So it's quite involved and a lot of multidisciplinary working for those kinds of assessments. Okay, so moving on then to the interventions. Now I'm focusing quite heavily on the communication side. I will come back to the eating and drinking side, but as was mentioned in my introduction, I do have a particular interest in working with people with communication difficulties. So I perhaps favour that a little bit, but I will come on to the eating and drinking side as well. So in terms of interventions, as I said, we base this quite heavily on the assessment and looking at those strategies that we can give. Strategies I tend to give some to the person who's been referred to me, the person with dementia, but also to the people who are caring for them. I often say to people that if you're really struggling for a word, the last thing then you want to be thinking is, now, what did Lindsey tell me I had to do when I can't think of a word? And have to then recall those strategies. So it's really important to give the prompting, the facilitation strategies to the caregiver so that they can assist the person when they're struggling to communicate. We might also look at alternative means of communication, and these are particularly important in the earlier stages when someone can use the skills that they have to learn how to use a communication aid. If someone has quite significant communication and cognitive problems, it might be more difficult for them to learn to use an aid, and they still have to have the abilities to be able to recognise a picture or read and understand a word, so they still have to have those language skills in order to use those communication aids. But we have had varying levels of success in using both high and low tech communication aids for people, though I sometimes struggle with some of the high tech ones because I'm not that technical myself, so sometimes it requires a bit of skill educating people surrounding those. We also get involved with with our occupational therapists within our service to look at the life storybooks and the memory albums, and I use these quite often in different ways. So sometimes they would just be word-based life storybooks for people in the earlier stages. Sometimes they would be then more simplistic for people with more severe difficulties to use. But they can be a really good shared focus of conversation for people. So I do recommend those quite frequently, to have a book with the kind of key topics that someone might want to discuss, because it can really help for any of us when we go in to meet with someone if we've got that shared information and a bit of knowledge about that person. Okay. We also do get involved sometimes in communication groups. So sometimes it might be like the post-diagnostic support groups, sometimes more aphasia aphasia therapy-based groups, looking at kind of total communication, supporting people with embedding those strategies that we've talked about. And sometimes it might be carer support groups as well, for giving information and problem solving around how to support the person that they're caring for. So coming on then to the eating, drinking and swallowing difficulties and the speech and language role within that. So obviously the swallowing assessment comes as part of our role and is often fairly straightforward, the assessment. It fits in with other client groups, the kind of skills that we draw on, but it's often in the management that it can be quite different to some of the other client groups that speech therapists work with, particularly if someone's perhaps approaching the end of their lives, or people have quite significant swallowing problems. We always look then at managing the risk of aspirating, the risk of choking, but as well as that, looking at perhaps some more positive risk taking than some of my acute colleagues would take part in. In the kind of acute settings, it tends to be putting people on more restrictive diets because they're acutely unwell. But for a lot of the people that I work with who are in the community and enjoying their meals, then putting them on a lot of restricted diet often impacts on the quality of life. So there's quite a lot of negotiating goes on in terms of looking at reduced risk but increased quality of life as well. And I'll talk about this a little bit later on with the case studies that I'm going to present. So we also have a role in training. I'm asked quite often to do training for it might be other healthcare professionals in care homes, for family members, as well as for students and non-professional speech and language therapists, non-specialised, speech and language therapists as well. So those who are working in other clinical areas. And this is really important to provide this training, looking at communication difficulties, looking at the dysphagia side and also the mealtime management. We also get involved in training regarding challenging behaviours that challenge, giving training around that in helping people to recognise that behaviour is a means of communication. So that's something that we get involved in as well. And another area that I'm quite interested in working in is to do with end-of-life care, and I think speech and language therapists have a really key role, particularly for those people with very severe swallowing problems, in order to support people to make decisions around their eating and drinking, but also in planning for end of life as well, in supporting people who might have communication difficulties but who might have the capacity to make decisions about the end of life, in supporting them to do so and make the the advanced decisions, as well as if then people don't have the capacity to make decisions and don't have an advanced plan in place, supporting family members with all the information that they need to make decisions around eating and drinking at the end of life. And again, I'll talk about this in a bit more detail for one of my case studies. So that's a bit of a whistle-stop tour so far of what speech and language therapists do. As I say, it is quite varied what we do, and we do get pulled into lots of different things. There is some overlap with other professions, but we do have a lot of unique skills as well that can be pulled into the memory clinics and the multidisciplinary teams. So I'll start then with my first case study. So my first case study is Rose. Rose was referred to me because of deteriorating communication, but with relatively intact memory. Her husband reported that she tended to forget what had been said to her rather than forgetting events, and including recent events. So she could remember what she'd had for her breakfast, she could remember what she'd done yesterday, but it was retaining some of the information that had been said to her that was difficult for Rose. Now, a bit of background on Rose. She was a very confident lady, used to do quite a lot of public speaking. She won a community award for the work that she did within her community, hence the rosette that I've used to represent Rose, because she did do a lot of community work, and as her communication got worse, she lost a lot of confidence, she withdrew from a lot of her social activities. So I was, a referral was made to myself to go in to assess to help with diagnosis, because this lady hadn't received a diagnosis at that time. And we did quite a lot of communication assessment, because although Rose notices a lot of differences, she is still able to communicate at a reasonably high level. And she was quite keen to find out what it was that was causing these changes. She was very keen to participate in assessment. Now, Rose has quite a significant hearing impairment, and she lip reads to help her understand what people are saying. And she finds that she's getting more and more tired in being able to do this. She's developing macular degeneration as well. So her eyesight's worsening, and she's really struggling to be able to lip read, and she gets very fatigued with it. But we did assessment over a few sessions, and Rose did really well on the assessments, but she struggled with some of the perhaps what we would expect to be easier for someone with her kind of communication style. She struggled with the kind of word picture matching. So when I was asking her, giving her a word or giving her a sentence, she was struggling to process that. But in terms of her memory, all of the non-verbal memory assessments she did absolutely brilliantly with. So did a lot of assessment, analysed that, discussed it with our psychologist who'd done the neuropsych assessment, and Rose has been given a diagnosis of semantic dementia based on the assessment that we did with her. So in terms of intervention then with Rose, we've done a lot of work with strategies with Rose, with using a vocab book, which Rose uses really, really well. So she writes the words in there, and we discuss some of the meanings of words, and we categorise it by places that she goes to, because to categorise it in, to put it in kind of semantic categories wouldn't be useful for Rose. So instead she started, for example, attending a gardening group which the OT set up. So we have a vocab page for the gardening group with the kinds of words and phrases that might come up that might be difficult for Rose to understand. And she then writes in the meaning of those words so that it's in words that she understands, to enable her to kind of follow what people are saying. So we use a vocab book, and that's working really well with Rose, as well as then giving some strategy. She lives with her husband, so we've done a lot of work with him as well, because it was quite hard for him to understand why Rose wasn't following what he was saying, and why sometimes she would talk quite fluently, but there wasn't the content there, it wasn't making sense to him. So we've done a lot of work with the two of them, and the psychologist has been involved in doing some kind of relationship-based therapy as well with them. So that's Rose, so that's one example of being involved with the kind of diagnosis stage, and then the intervention that we put in place with her. So moving on to John, and the image will start to make sense. John's a gentleman who is in a care home, and he was referred with very vague information about possible dysphagia, some issues around meal times, challenging behaviour, throwing his plate and his cup across the room, hitting out at staff. So a lot of difficulties for John, and the community nurse that was involved in his care was concerned that there might be a breakdown of that placement, and that they wouldn't be able to manage John anymore. So my initial, John has a diagnosis of vascular dementia, and had a history of stroke prior to that. So I went out to see John over a mealtime, and on assessment he didn't have any kind of physical dysphagia, but I was able to observe him over the mealtime and his interactions with the staff. And I suppose for speech and language therapists are privileged often because although we are very busy, we often can have slightly longer appointment times with people, and we can, we're trained communicators and to observe communication. So often by us sitting and observing someone in a structured way, we can try to work out some of the reasons behind the behaviour. So for John, one of the key things, they just gave so much information to him. It was constant of, John, these are the options for lunch. What option would you want? And he didn't respond. So, oh, well, you normally like this, don't you? So we'll give this to you, John. So we put it down. He doesn't eat it straight away. So then they start to assist him. And that's when he pushes staff away because he doesn't want them assisting him. And they're, oh, John, you must eat because you're losing weight. You must eat. Come on, John. If you don't eat, you'll have to go into the hospital. The doctor said that you'd have to. Lots of this kind of verbal overload of information for poor John, who just wasn't processing the information. And certainly didn't like, oh, that's why I've got, don't stand so close to me, because of the personal space that they kept invading for John. So actually John in himself, I also found for John that they only engaged with him when there were care needs. So it was they only ever engaged with him at mealtimes or if he needed help to use the bathroom, or if on a morning when they were assisting him to get ready. There was no social engagement with John. There was no sitting down with him 10 minutes before dinner to have a chat with him or just to spend time with him. He just, I assume, he just saw the care staff as these people who came and made him do stuff. And that was the impression that I got when I was observing John. So John in himself didn't really need a lot of input from me. What he needed was to have well-educated staff working with him. So the main part of my input was to educate staff, to look at strategies at meal times, to look at not giving too much information. I reference a lot to, do people know about Tom Kitwood's work? He's done a lot of work in dementia care, and his book Dementia Reconsidered is one of my Bibles, and I often talk a lot about some of the personal detractors that he talks about. He talks about outpacing, going too quick, talked about the kind of intimidation of you'll have to go into hospital because the doctor said, as well as just not giving him those social opportunities, only engaging with him during those care need times. So we also then worked with the activities coordinator and with the care staff to look at ways that they could engage with John outside of meal times and care need times. We used some of the principles of intensive interaction with John to let him take the lead when people are engaging with him, and looked very much at then giving John that personal space. And touch wood, he's still in the care home that he was in. His behaviours have reduced at meal times, but it's an ongoing battle because care staff, they change. There's a high turnover of staff. So it's a kind of constant battle. But we have got the care home liaison team on board with the recommendations for John, so they're able to reinforce them. So we've not fixed the problem as yet, but certainly we've made progress towards that. So moving on then to Margaret, and she's one, I know you're not meant to have kind of favourites, but I do have a bit of a soft spot for Margaret, mainly because I get a beaming smile whenever I go to see her now. But Margaret was a lady who'd had a stroke about 18 months ago, and she had some cognitive decline since then, but she was admitted to an acute hospital and she was put on my least favourite recommendations of puree diet and custard thick fluids, which I never, well, I don't really recommend, but in acute care then it was needed for Margaret. But she'd come back to the care home and she was unhappy with these recommendations. The referral, she was refusing food, she was stealing food from other people's plates, wasn't a very happy lady at meal times, quite either very low or shouting out, and could be quite argumentative. and has communication difficulties because of the stroke that she'd had. So I went out to see Margaret, and the first thing I did was talking mats assessment. I don't know if people know about talking mats. So it's kind of a structured way of engaging with someone using cards with pictures and words on, and you use that to structure and keep focus on a conversation. Or that was the way I used it for Margaret. And we talked about food and eating and drinking, and Margaret was very clear. We had a kind of happy with, not happy with, and pureed food went right down that end as far as it could go. She was not happy. And sandwiches and cakes were up on the other side of the scale. We talked about some of the risks. I did a capacity assessment with Margaret using this talking mats structure, and asked her what might happen. So what would happen if you had these more complex foods? What are the risks? And she was quite clearly able to choose choking and chest infections. She chose those. So she demonstrated that she had some insight into these, the risks. So I saw Margaret then over a tea time, and it was so sad. They had these beautiful trays of sandwiches, cakes, toasted tea cakes, crumpets. They had all of these out on trays, and the three other ladies at Margaret's table were offered these. And I saw, what's Margaret having? A bowl of scrambled egg, followed by a bowl of pureed banana and custard. And they wondered why she was stealing food. So I said, well, while I'm here, we'll give it a go. I'm the speech therapist. I'll take responsibility. We'll try her on some sandwiches, nice soft filling, crusts off. You know, we'll cut them up. And she actually managed quite well. There were some quite a lot of residue. She took quite a long time, but she was beaming. She was really happy that she could have these sandwiches and cake. So we had a meeting with Margaret, with the other professionals, and we decided that it was definitely in her best interest. We felt she did have the capacity to make the decision, but we also felt it was in her best interest for quality of life. Margaret now doesn't steal food, which is lovely, because obviously sometimes there's higher risk foods on other people's plates. So we're not just going, yeah, just have your crusty bread with your lettuce and tomato. We've kind of got a happy medium of the kind of softer sandwiches. And whenever I go in now, big smiles, and I always say to her, how are you managing? And she touches her throat and she holds up two fingers, say, I have to swallow twice. She knows that's what she has to do. And we do have written reminders in case she forgets. But she always knows that she has to swallow twice, so I'm confident that she understands those strategies. So a real success story for Margaret there. Now I am aware of the time, and I've just got two more case studies which I'll just whiz through if that's okay, because I think they're quite important ones. Vivian, I wasn't sure whether to include Vivian in this presentation, because she's not really a success story as such, but I think demonstrates the need for specialist speech therapy involvement. So Vivian had a diagnosis of young onset dementia, and when she was referred to me, she had very poor verbal communication skills, was quite cognitively impaired, and she was struggling with eating and drinking. She had no advanced decision in place about eating and drinking. We did the assessment. She was quite at risk. I won't go into the details of the swallowing assessment, but she was at risk on some of the high-risk foods. Now, one of Vivian's favourite foods was breaded mushrooms, which aren't the easiest things to manage. But with, you know, mayonnaise and ketchup and things, we decided because she loved them so much, we weren't going to say she couldn't have them, but smaller quantities with easier to manage other food. But Vivian, she managed on these for a little while, but then she deteriorated quite rapidly, and she did actually get a chest infection. Her husband wanted to keep her at home, but she had breathing problems. It was Friday night. She was admitted to hospital the early hours of the Saturday morning because of these breathing difficulties. And when I rang the speech therapist in the acute hospital on the Monday morning to hand over, she said to me, oh, they're considering non-oral feeding. They're considering a PEG. Now, people may or may not know that the evidence doesn't support using non-oral feeding in the later stages of dementia. It's not been shown to prolong life. It's certainly not been shown to improve quality of life. And this was what I then rang the ward. I don't kind of have any I can't just go on to the acute wards. They have their own speech therapist, so I can't just kind of go on and kind of tread on their toes. But I spoke to the speech therapist there about the evidence. I spoke to the ward staff, the consultant, but they did go ahead anyway and put the peg in because she was a young lady. They said she's young. We want to give her every chance, and I said, well, this isn't giving her every chance. Vivian then made her own mind up, and she actually pulled the peg out and got a very nasty infection, which I could have predicted, very sadly. So I then was on the phone to her husband, giving advice about careful hand feeding. He was very worried she might choke. He was very worried she wouldn't get her nutrition. And we kind of discussed that really at this stage it was the careful hand feeding of giving small amounts if Vivian wanted them, which she did. And actually Vivian died 2 days after pulling her peg out. And it was a real learning curve for me. And more so for the acute therapist who I then met with to kind of give them some education about using non-oral feeding for people with dementia. So I kind of put Vivian in there because I hope that if any of you in your professional roles, if you come across a situation like this, you know, do check out, email me, and I will send you the evidence, a summary of the evidence, because it's really important that this doesn't happen to more people like poor Vivian. But she had her husband with her, and she had sips of fluids and teaspoons of yogurt and things right till the end. So I had to put Vivian in because I just felt it was important to discuss that with you all. But I'll end with Jean, who I also have a soft spot for. Me and Jean have a joint love of the song The Lambeth Walk, which I don't know whether many of you will know, but my grandma used to play it on our piano when she used to come round. So luckily I know the words, and Jean has a good oi at the end of the chorus. So Jean was referred with my worst referral reason, can't communicate. And I would say that everyone, unless they're unconscious, can communicate. And Jean's husband was finding it more difficult to visit Jean and to know what to talk to her about. So I did a lot of informal assessment with Jean. It wasn't appropriate to formally assess her because she wasn't able to engage with the assessments. Lots of kind of observation, engaging with her, and she actually communicates very well. Although she's not verbal, she vocalises, and she has a real good range of intonation in her vocalisation, so you can pick up on her mood from that, as well as her facial expressions, her body language. She likes to touch. She'll hold your hand and stroke your face, and will sometimes kind of take your hand to stroke her face, and she's very, very tactile. And I've kind of educated the staff that this really is a means of her communicating. So we've looked at different activities for Jean. I've worked with the OT and the activities coordinator, as well as with her husband. And Jean loves having her nails painted. She loves the hand massage. She loves music. She likes it when the therapy dogs come in. She likes having a bit of a potter in the garden. And really for Jean, it was a lot about educating the staff that this is how you engage with Jean, and as well to her husband, because he felt because he couldn't have a chat with her, he couldn't engage with her. So it was really important for us to look at ways that he could still engage with Jean that didn't rely on speech and on words. And actually he now, he visits every day, and he stays for longer and longer, and we have a little activities book of things to try with Jean, and he can then, if he's not sure what to do with her that day, he can have a look in his the activities book and choose something. And he'll sometimes offer her the choice, and she isn't always able to make a decision, but because she enjoys everything, whichever she points to, he takes that as her choice. And she's generally happy then with the outcome. So that's Jean. So I hope that's given you a real range of what it is that speech and language therapists can do. And giving you some ideas that perhaps if you don't have a speech and language therapist within your team, you can write your bids for funding forward. And I wish you all luck with it. So thank you very much for listening, and any questions?